As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee, and the time is 1:01 p.m. Yes. It's on. Try again. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communication, and today we would like to do this in concert. So we're going to do the strategic planning meeting, public communication, and the budget meeting, public communication. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Brianna, did anyone register to make comments for the strategic planning committee meeting or the budget meeting? Yersinia. Did anyone want to make public comments?
No, Madam Chair, nobody signed up to make public comment for these meetings.
Okay, thank you. So we will now proceed to the committee agenda. So number one, review and approve the minutes of the November 9th, 2022 meeting of the Strategic Planning Committee. Does anyone move that the committee approve the meetings? Yes, Manager Jones.
I move that the committee approve the minutes of the November 9th, 2020 meeting.
Thank you.
I don't think I was recording. I move the committee approve the minutes of the November 9th, 2020 meeting of the Strategic Planning Committee.
And do I hear a second? Okay, thank you. Thank you. And all in favor? Aye. Any abstaining? Let it be shown that Manager Kitchen is abstaining from the meeting, from this. Okay, so thank you. And number two, receive an update on Central Health's ongoing equity-based systems planning work and operational and financial sustainability planning, which will include developing plans to implement the board-adopted healthcare equity plan. Monica Crowley will be presenting with Dr. Abhi Sharma, Danielle Srinivasan, and Julia Clark from Guidehouse. Thank you. Welcome. Happy New Year.
Okay, I think this is working. Thank you, Mike. Is that good? Thank you. And thank you, Chair Brinson. Dr. Sharma is going to be presenting remotely today, and we've got Danielle Srinivasan here to update you on this work. Of course, this isn't going to be as robust of an update as the one we're going to receive next month, because Danielle and Abhi presented last month as well. And then we also have Aaron Swindinson, or so, yeah, in the room here with us today from Guidehouse. So Danielle.
Thank you, Monica, and thank you very much for your time today. So if we jump to the next slide, please. What we really want to do is just provide you with an update of the work underway and what we've completed so far. So a lot of great work has happened since we last met, and really just want to thank the Central Health team for their continued efforts, because they've spent a tremendous amount of time and resources to really help us get to where we are today. And then what we'll do is spend some time this afternoon just to show you an illustrative example of what the work will look like over the next several weeks as we shape out these deliverables and what some of our recommendations are. So at this moment, I'm going to hand it off to Dr. Sharma, will provide us with an overall engagement update and then walk through the next few slides.
Perfect. Thank you, Danielle. Can everybody hear me? Okay. So, like Danielle mentioned, our agenda for today is focused on a couple of things. First of all, we want to provide an update on the progress of this engagement. We then want to level set on some of the guiding principles that have helped us throughout this engagement in identifying what our priorities are and how do we go about addressing those priorities. And towards the end, we want to share some sample outputs of what would come out of this engagement in terms of the initiatives that we want to focus on. And again, it's illustrative just to provide a flavor of the outputs that would be generated from this engagement. So we've made significant progress till date, and the Central Health Leadership Team has been extremely helpful in guiding us through the process. And it has been a collaborative process with a lot of meetings between the Guidehouse team and the Central Health team as we think about what our priorities are and how we spend our monies moving forward to address the needs in the community. So just to bring everybody up to speed, the first phase of this engagement was focused on identifying community needs. And what came out of that assessment were two things. The first one, as I mentioned, was a list of community needs, the scale of those needs, the magnitude of those needs, as well as the geographic distribution of those needs. The second key output of that phase was a list of strategic imperatives. So if we think about addressing the needs that lie in the community, what are the strategic pillars that we need to focus on so that we can move the needle and continue meeting the needs of the community in a progressive way? We use the output of that engagement to start this phase of the work that we are continuing right now. So based on the needs that were identified in the first phase, we ran an assessment that allowed us to prioritize those needs based on a specific set of criteria. Now, these criteria were primarily focused on two things. The first one was the scale, the magnitude, the distribution of those needs. And the second was the amount of effort and financing that would be required to close each of those needs. Now, we are at a point where we have a short list of these prioritized needs, and now we are taking those needs and creating well-defined strategic and operational initiatives that allow us to address those needs. So when you think about these initiatives, think about things that we as Central Health can do to meet the needs that lie in the community. An example would be improving access to primary care by providing direct care as well as contracting with more primary care physicians. Another one would be beefing up specialty care capacity and access by opening up specialty clinics at RZ and Hancock. And there is a list of initiatives that we have been able to get to based on the analytics and the discussions that we have run and again, the discussions that we've had with the leadership team. Now, moving forward, what we want to do is we want to take the initiatives that we've identified, think about the capabilities that would be required to execute those initiatives. So when you think about capabilities, think about the personnel needs, think about the technical needs, the process needs, and the financing needs that are required to execute those initiatives. So once we lock down our initiatives, the next thing that would come after it would be identifying of those capabilities. And then we also want to think about financing with a greater level of intensity. So what we want to do is for each of these initiatives, we want to draft a financial sustainability plan that would focus on identifying the upfront cost of standing these initiatives up, and then also the continued costs that would be required to keep these initiatives ongoing into the future. At the end, what we would deliver would be operational roadmaps that take each of these initiatives and walk these initiatives through different timeframes to see how we can start from where we are and get to a level where these initiatives are fully sustainable. And we also want to see how each of these initiatives tie with one another. As an example, care coordination is a key initiative. And as you can imagine, care coordination impacts primary care, specialty care, hospital care. So at the end, we will also have a operational roadmap that shows the dependencies and synergies that come out of these initiatives. Another key output would be a financial plan, which, like I mentioned, would at the initiative and at the global level, identify the financing needs to stand these initiatives up and to sustain these initiatives over a long period of time. Next slide, please. Now, we've seen this slide a couple of times, but this slide is really important because it paints a very accurate picture of what a high-performing safety net system is made up of. So towards the periphery, you see the care delivery areas that we need to build or improve into the future. And right at the center, you have the core services like navigation and IT that are required to sustain the system. The key message of this slide is that a lot needs to be done. And for the system to function efficiently, all of these different parts need to work in cohesion with one another. And we need to think about how these parts impact one another, as well as the synergies that come out of the execution of these individual initiatives that would help us meet the needs of the community and improve access and capacity within the system. Next slide, please. Now, like I mentioned, towards the end of the previous phase, we came up with the strategic imperatives that would essentially be the guiding principles that guide us as we think about the initiatives and start prioritizing initiatives that we want to focus on. The 4 key strategic imperatives that came out of our first assessment were, number 1, access and capacity. We need to think about improving capacity as well as access in the community so that our patients can get the right care at the right time and at the right place. The second thing that we want to focus on is care coordination. We know that our patients move from primary care to specialty care through to hospital care, but there are a lot of times when patients fall through the cracks and causes our patients to get to a very acute stage of illness, which could have been prevented had they not fallen through the cracks. So care coordination, making sure that once the patient engages with the system, that patient stays with the system and then uses the system to improve his or her own healthcare status is going to be front and center through the care coordination strategic imperative. The third strategic imperative was member engagement. Our population is unique from the epidemiological point of view, from the clinical point of view, and from the demographic point of view. Everything that we are doing is focused on our patients. We are using tenets of social determinants of health, personalization of care, and cohort level analyses to identify what our members truly need. And as we think about these initiatives, we will focus on how we can engage members in a better and more efficient way. The last strategic imperative was the system of care that we want to create. We know that for the care that our patients get, they depend on access points that lie within different organizations in Travis County. So a lot of acute care is delivered at St. David's and Ascension. Outpatient clinics are also outside of the CUC system, and then for primary care, we typically depend on CUC. So as we think about addressing member needs across the continuum of care, we need to think about how each of these components works with one another to create a system of care that is targeted towards the members and allows patients to seek care across the continuum of care depending on where their healthcare needs lie. Now, for us to think about these strategic imperatives and then make tactical decisions and execute initiatives, we also need to think about the core elements that would be required for us to achieve these strategic goals. The first one is clinical staff. We know that there is overall shortage of clinical FTEs across the board, primary care, specialty care, you name it, and we are seeing limited availability of clinical staff across the nation. So we need to make sure that we think strategically about where staff is available, and if we cannot hire folks, what are the other ways for us to beef up capacity by either getting into contracts or partnerships with other organizations. Number two is administrative staff. So for clinical staff to do their work, we need an administrative back end that provides support as and when needed. The third is IT and system capabilities, EMR capabilities, triage capabilities, capabilities around scheduling, enrollment, all of those things form the center of the system. So as we think about evolving the care model, we also need to think about where these capabilities would come from and how we mature the existing capabilities so that the system that we want to get to is efficient when it goes live. The fourth one is data management. Data is the lifeblood of healthcare. We need data sharing between providers. We also need data sharing between patients and administrative staff members so that the process is seamless and that the needs of our patients are identified and then care is delivered to them in an appropriate way. Number five is contracts and agreements. Like I mentioned, we work in a system of care, and we need to make sure that we are assessing contracts and agreements to make sure that the needs of our patients are met and that accountability standards are clearly mentioned in these contracts so that if we are paying our partners or our contractors for the care that they're supposed to deliver to our patients, they are really held to those standards and that there are back-end processes that allow us to do that. Number six is fiscal capacity. So we need to do a lot, and we need to make sure that the finances that we have are being used in an appropriate way. In order to do that, we will have to make trade-offs. There will be times when we will have to make tough decisions around where community needs are most and what initiative allows us to meet those needs in the best way. And that would enable us to use our fiscal capacity in a better way and would allow us to make sure that we are making the most out of the finances that we have. Number seven is infrastructure. So physical infrastructure, multi-specialty care sites, ASCs, diagnostic facilities, all of these things need to be taken into account and brought into the system as we think about where these gaps exist and what the most expedient and efficient way for us to close those gaps would be. So again, the key idea of this slide is that we are focusing on these four strategic imperatives that are guiding principles, and a lot of capabilities and elements need to be built up for us to use these strategic levers and then prioritize and execute on our initiatives to meet community needs. Next slide, please. And as we transition from the strategic imperatives to some of the key community needs that we are seeing, I want to level set on how we have structured these needs. So right at the top, we focused on the clinical areas of need. Primary care is one big area. Then you have specialty care and hospital-based care. And if you read the text that is within these boxes, it gives you a flavor of what the actual need within these buckets is. But the key idea here is for us to focus on clinical needs first, and then think about the other needs that are required for us to be addressed so that those clinical needs right at the top are also being met as we start executing on the initiatives. So underneath these top clinical needs, we have cross-cutting services. Now, if you think about cross-cutting services, these are agnostic to the different areas of clinical specialties. And an example here would be care coordination. Like I mentioned, care coordination is a service that would impact all of these clinical buckets. And we also need to think about what some of those cross-cutting initiatives would be that would allow us to create a cohesive system that's based on the continuum of care idea. Right at the bottom, we have needs and services around coverage, so enrollment and eligibility are going to be focus areas for us. We will also look at social determinants of health. Now, as we know, our populations are truly unique, and the best way for us to increase adoption in the community is to create member-specific and population cohort-specific disease programs, and to usher in this idea of culturally competent care through trainings that would allow us to engage better with members and keep them within the system once they start engaging with the system. So the idea here is, again, for us to start thinking about how we meet clinical needs. Then level 2 is how we ensure that the cross-cutting services that are required are synergistic with the provision of those clinical needs and how they act as threads that bring the system together. And then right at the bottom, we also need to think about how we can bring more people into the system, as well as create a culture that is aimed at providing personalized member-specific care to our patients. Next slide. Danielle, do you want to speak to slide 7 and onwards?
Sure. Thanks, Abby. So,
Sure.
next slide, please. So on slide 7, what we're showing you here is a slide that you have seen in the past, right? So this is the gaps that we had identified in our phase 1 work that are serving as the foundation for all of the work that's to come. So what we are doing is looking at what are the most critical gaps that the safety net community experiences in terms of healthcare needs across Travis County, and developing initiatives that are going to be impactful so that we can close the gaps and really improve access and equity to high quality services across Travis County. So within this, we're looking at closing the gaps across these 3 major domains: primary care and wellness, specialty care, behavioral health, and dental services, and then hospital-based and post-acute care. So within each of these domains, so I'm going to start with primary care on the far left and work my way across. But primary care is really about timely service and access to the social services so that we can make care more accessible and quality. When we think about wellness and prevention, we know that based on the findings from the CHNA, there's great opportunity to really advance access to wellness and prevention services to improve outcomes for the Travis County safety net community. So in that regard, it includes patient and education and communication. So do patients know where to go to receive their care? How do they access the system? Do they get the communication from their providers that it is time for their wellness checkup? Also looking at screening, and then really engaging the patient in their treatment plans. So the diet, the exercise, the nutrition, really, how do we empower our patients so that they're engaged in their own wellness? And then looking at urgent and convenient care. So what options exist that would be optimal for the safety net community in regards to virtual health or telehealth consults? How do we make care easier for them to access? Where do we have same-day appointments available so that our patients are not taking the entire day off from work and waiting to be called? So how do we really make care accessible for the safety net community, and what are the models that are going to work? When we think about specialty care, it's really, again, going back to Abby's points earlier, but expanding that access to the critical services that are needed so that their patients are getting the right care at the right time. We know that this is a very unique patient population. Many have several comorbidities and require multidisciplinary treatment planning. So how do we make sure that we have the right specialties available for our patients so that we're able to improve their outcomes versus receiving care when it's most critical? So being more proactive. Behavioral health, we know, is a significant need. and really looking at holistically across the behavioral health spectrum. So how do we provide access to substance abuse disorders, mental health, and really helping to advance that, and then aligning these models with primary care and other specialty care models. And then dental services. So we know that our partners through CUC and others provide dental care, but how do we really expand access so that we're offering preventative as well as specialty dental services for our patients? On the hospital side, really going back again, so right care in the right place, in the right setting. So when our patients are having an acute episode, they're receiving the right care, timely, getting the medical and surgical consults that they need so that they're receiving the care to have a quality outcome. With that said, there also comes, treatment planning, care coordination, patient navigation, really making sure that our patients are receiving the care that they need and are being discharged to that post-acute care setting that will really help them continue on their path to wellness. Next slide, please. So quite a bit of work has been done over the past several weeks to really advance closing the gaps. So what we have been doing with the Central Health team is developing initiatives to address these key gaps based on these high priority needs across the safety net community. We have met several times with various work groups and subject matter experts to really fine tune what the initiatives would look like based on best practices, based on the voice of the community work that we heard a year ago. So what is going to work for this community and what does that optimal model look like for the future? And we continue to work with Central Health to really refine these initiatives so that we are really getting this right and we're putting a plan in place that will be impactful and really build that future healthcare delivery system for the safety net. So the initiatives span across 5 major domains. So primary care, specialty, behavioral, and dental, hospital-based and post-acute, foundational enablers, which are really those cross-cutting services that will really enable care and for us to be efficient and effective. And then the other category includes addressing the social determinants of health to really make sure that we're building a model that considers the social challenges our patients experience so that we make access easy. Next slide, please. So this slide here represents essentially an illustrative example of a swim lane of how these initiatives will be laid out as we think about timing, resources, and interdependencies. Because what we want to do here is really build upon all of the good work that's happened to date and then forge ahead together. So when we think about those key initiatives, it's thinking about the people, the processes, and the technology that will be required to really hardwire these initiatives and execute successfully. Next slide, please. So in terms of next steps, we have quite a bit of work and activity over the next several weeks. We're working with the Central Health team to refine and draft the prioritization of these initiatives to really assure that we're meeting in designing a model that meets the Travis County safety net healthcare needs. We're going to begin looking at Central Health's capabilities, so doing an operational analysis across key functions to really understand where we stand today and how we're positioned to execute on some of these key initiatives. And then what we will do is we'll provide an update on this work during the board meeting in February. And that brings us to the end of our presentation.
That's Excellent. Thank you so much. Does anyone have any questions? Yes, Manager.
Thank you for that presentation. I'm glad we're moving forward. Now, the question that I have, it might be for staff. I know as this is a long process, we're looking at a timeline 5 years out. In the meantime, how are we taking care of the existing patients we have? Are we working in parallel? I just don't want us to neglect what we have now. And definitely we need to think about the future, but also address our our immediate needs. So wondered what you had.
So, we're good. Thank you. I'll start off answering, and there's no shortage of people in the room that could provide a great deal of detail on all sides here. The work that we're doing now on the different lines of services continues. Expanding those lines of services is laid out in our budget. It's in our budget resolution. The board is not only given us permission and sanctioned us, but resourced us to be able to do those things. So that work is still congruent. And so it's not with what the planning that we're doing here. And so it's not like we're maintaining status quo on anything until we get all these operational plans in place and then we kick it into gear. Everything is still building up and expanding as we speak today on all the different lines that we've reported on already and will continue to report on throughout the fiscal year. I think what's important about this, and I'll pause there to see if there's a more detailed answer that is responsive to your question, is in looking at these operational and financial sustainability plans and the various roadmaps or swim lanes that are going to be presented to the board, we will need to think critically around how we build out the operations. And it's been more than just alluded to. It's spelled out very clearly in this presentation about how we build out the support necessary to get us to where we need to be in terms of filling the gaps, be they moderate or significant in the healthcare system. So I say that because I don't want to overshadow, while we're doing all this work to clinically meet the needs of our patients, there's a lot of work that happens behind the scenes in order to be able to make that.
I would just say, I think if you think in terms of kind of nested plans and programs that are set out, you have the larger healthcare equity plan that you guys adopted last February. The initial kind of work around operational, financial, and sustainability planning that came out of the healthcare equity plan got incorporated into the fiscal year 2023 budget resolution strategic priorities that you guys adopted. And that work is continuing and is underway. And some of the things that you think about are the Rosewood Zaragoza, the continuation of the building out of the health centers in Hornsby Bend and Del Valley and Colony Park, things like the transitions of care, the additional work on respite, and then other things that I'm forgetting right now, but that are in that budget resolution, the looking into the overall cancer continuum and the work with the Black Men's Health Clinic and community care, or at least two of the other things that came out of this work. And I think there's going to be this kind of expanding and funneling as we look at the operational and financial sustainability planning work. There's going to be work that is going to reinforce and build on the work that's already underway in this current fiscal year. There's going to be work that's going to lead to recommendations for fiscal year 2024 budget priorities. So there's immediate work, there's near-term additional work, and then all of that work is feeding into these longer-term plans that might come to a fruition in another 2 years, and another 3 years, and another 5 years. And so I think, I kind of look at it as it's not really an accordion, but it's all kind of nested under. And sometimes we go back to the overarching plan to determine kind of what the next step is, or needs shift in the community. And so things might be reprioritized, but it's kind of having this North Star for the system that our immediate, daily, monthly, annual biennial work plans are working towards.
Any further questions? Yes, Manager Kitchen.
I'm excited to be here, and I think I'm going to ask a question that you may all know, in which case I can learn more about it offline. I'm curious about the timeline for the, can I get it turned on here?
Yeah.
The timeline for the initiatives. So for my first question, is there a list of initiatives already that's been adopted? And then if you can point me to it. And then the second thing is, I understand that this is a build out of each of those initiatives. What's the timeline for getting these back?
Well, and so there are needs that have been identified
Yeah.
as part of the healthcare equity plan.
Mhm.
And then there are additional kind of needs that have been identified that were also part of that work session with the board last month. And then we are in the process of developing the list of initiatives
Okay.
now. And so I'll hand it back to you, Danielle, with.
And as you're answering the question, talk a little bit more detail around the deliverables.
Yeah,
Yeah,
when
absolutely.
exactly? Because, so I understand you're in the process of developing the list of initiatives. So when will that be coming to us? I guess is my question.
Yep, all great questions. So we are working over the month of February to really fine tune the high level initiatives, right? So these represent kind of the swim lanes, if you will, for each priority. And then what we will do is bring that back to the board to, to kind of, present to you to make sure that, we're on track. So I suspect that that's going to be, I think we're still working on the timeline, but it's going to be fairly quickly. So what we need to do though is just go back, vet it with the subject matter experts and the work groups for central health, make sure that we're getting it right, and then we'll be bringing it to the board in very early spring.
Okay.
I suspect. The timelines, so this represents a very high level illustrative example, but as an output to this work, the timelines will be much more detailed. So this is kind of the summary level, but to back this up, you're going to have Excel spreadsheets with, hundreds, thousands of rows with very specific dates that are much more finite and detailed and specific from what you're seeing here, which is a short-term, medium-term, and then longer-term timeline.
Mhm.
And that work will be completed once we get sign off on the initiatives.
Okay. So a next step for the board as a whole is to adopt the initiatives? Is that how?
I think we'll get feedback on the initiatives, and then once the feedback on the initiatives, are these directionally correct? Or are we missing anything? Is there anything else that we
Okay.
need to consider? And then there's the build out of the projects, the deeper, more detailed timelines and implementation and financial plans. And then later, I think, is it June? The board will adopt kind of the overarching plan that includes this larger roadmap. Or we'll bring it, I've said that wrong. We will bring a plan to recommend to the board for board consideration in
Okay.
June.
Okay, thank you.
Excellent. So does anyone else? Yes, Manager Jones.
Just two quick questions. One is, who can you speak to who within Central Health make up the team that you're working with? Is it staff? Is it consultants? Or well, no, you are, but I mean, are there others?
Sure. So we're working with a wide variety of folks from Central Health, so across the organization. So to really make sure that we're getting the subject matter experts that we need that are, kind of live and breathe this work every day. So kind of by area, we've been very prescriptive in who we're working with. But from a project governance standpoint, we're working across Central Health leadership to make sure that we're advancing appropriately.
Okay. Well, not now, but at a later time, could I get a list of those individuals? I think it would be helpful. And the second question is, where you talked about the draft initiative, primary care, specialty, behavioral, dental, hospital foundational enablers. Are you inculcating public health in terms of those efforts as well?
Yep, absolutely. So we're looking at kind of that broader healthcare ecosystem to really identify the most impactful initiatives that are going to advance this work. We know that some of this will have to rely on partners for, which would include public health, and really looking at what are those activities or actions that we need to take to make sure that this is going to be received by the safety net community and that this is going to be something that they really, value.
Thank you again. Yes, and Manager Kitchen.
One last question in terms of the timeline and the approach. What is the thinking about obtaining community input on the initiatives? And maybe you haven't worked that out yet. Do we know yet how that's going to be done? So I'm understanding that later in the spring and in June, we would be getting information back from the board about, a set of initiatives. So is there a process that's been considered yet in terms of getting community feedback on those initiatives?
Well, it actually started on the front end of this process with the voices of the community. So looking at the data that we had, and then through the community needs assessment, and then through the voices of the community work, help us understand the context around that data, because data doesn't tell you all the stories, it doesn't tell you everything. And then you triangulate between those two things, and that led us to the healthcare equity report that's driving this. Now, just by virtue of our community conversations that we have and our public outreach efforts, the fact that we're going to be building the budget around this, that is the venue for the community input. This will be, part of the onboarding process, but, going beyond just the statutorily required public meeting, there's a lot of outreach effort and built around the budget, starting with what is our strategic foundation? What are we building on, even before we get into any numbers? Which this is going to be, I would venture a guess with Jeff Knodel sitting behind me, 80–90% of the foundations of our budget.
Okay. The reason I ask is because I know there was a lot of really great upfront work done, around the community needs assessment and reaching out to the community. What I'm looking for is what is the touch back with the community? What's closing the loop with the community? All this great work has resulted in this list of initiatives. And what do you guys think about that?
It will be through our community conversations that we build around the budget.
Around the budget. Okay, that's what I wanted to know.
And Ted Barton I was looking to see if he was in the room right now, but he has continuing plans for, we have had community conversations kind of circling back with the community before the holidays. And so somehow, I don't, with the ice storm, my brain got wiped. So, but there were in the fall, in November, I believe, but Ted and his team would be able to pinpoint it like that. But there were community conversations that following up on this, and he does have an ongoing plan for continuing community conversations. I think also as we work on this kind of expand, you go to the higher level, you go deep down in the weeds. As we really get into the weeds on fully fleshing out and building out these initiatives, many of the initiatives are going to benefit from getting that deeper level of input from the communities that are to be served by the initiatives. And I think so it's this kind of, expanding track as you get into the weeds of how the program's going to, finally be implemented. We also have processes with the communications and community engagement team and with the, kind of program and project managers to gather that additional input as we're, kind of fleshing out actual initiatives that are being worked on, at any given point.
Okay, thank you.
Thank you so much. Anyone else? Seeing no more questions, just want to thank you all for your continuing hard work. I mean, it's really showing, so I really appreciate it. Thank you. So we'll move on to number 3, receive and discuss a presentation on the Central Health Demographics Report. Sarita Clark-Leach, J.P. Eichmiller, Ashley Leviolette, Matt Richardson, and Jesse Patton-Levine will be presenting.
Good afternoon, everyone. My name is J.P. Eichmiller. I'm the Senior Director of Strategy and Information Design for Central Health. We are here today to present the final findings excuse me, of our 2022 Central Health Demographic Report. Before I get started on this, I would really appreciate taking a moment to thank some folks. This has been a process that has taken, I don't know, approximately 9 continuous months to get us to this point. And I'd just like to thank all the people who dedicated their time and dedication to this. Monica Crowley is the executive sponsor of this project. I think this is the second report we've done together, and I can say has definitely come a long way over those these last 2 iterations. Matt Richardson, he is our senior data strategy analyst. He oversaw our analytics regarding chronic conditions and provided detailed narratives throughout the report. Jesse Patton-Levine is our analytics and quality manager. She does a lot of the behind the scenes data staging and stuff I don't understand, and also developed a new section in this report around our homeless population. Sarita Clark-Leach is the Director of Analytics and Reporting. She has been a steady voice in leadership. Whenever we've had questions about what we were looking at or if we were looking at it right, she has helped clarify those issues for us. And definitely not last or least to me is Ashley Leviolette. Ashley came to Central Health 3 years ago, and we had a vision of where we could bring our capabilities. And I can honestly say we would not have the product we are able to present to you today without her skill sets and knowledge. So the first demographic report was developed in 2015. This is our 4th iteration of the report. The purpose of collecting and presenting this data is so that we can identify the areas with the highest counts and concentrations of poverty in the county. Once we've done that, we conduct deep dives into those areas, looking at the demographics, looking at the enrollees, the patient utilization, looking at the burden of disease within those specific areas. Additionally, what's new this year, as we mentioned, we have now created a deep dive into our homeless population, which, as you can understand, because they are homeless, we haven't had a geographic analysis of them in the past, but they do represent about 8% of our total enrolled population and 25% of our MAP patients. We also, with Matt's guidance, have developed a health equity index. So we were able to compare subpopulations, the burden of disease, against the expected overall burden from our total patient population. Next slide, please. So we're just going to start off with the key findings to kind of set the stage, let you know what the main things we want you to take away from this report and this presentation today. A lot of these may be intuitive, and a lot of them may kind of counter beliefs, and there's a lot of evolution that's occurred, especially since COVID has changed so much. First bullet, the high cost of living and affordability. This is no longer an issue unique to Austin or Travis County. We are seeing in the surrounding counties, the escalating housing costs. You're no longer, people seeking affordable or low income starter homes can no longer go across the county line to Buda or into Round Rock or even areas like Hutto. So while Austin is in many ways the driver, excuse me, of this high cost of living, it is also in a unique position that it is the lead player in the region for providing safety net services. There is no other government entity within Central Texas that has the tax base, the systems in place, or even the political will to provide the level of services that the city of Austin provides. Poverty is becoming more concentrated along the I-35 corridor. In our previous report, we identified 12 communities, what we call our focus areas, that have the highest numbers and concentrations of poverty in the community. In this report, you'll see that number has gone down to 9. 4 of those areas, mostly in the outlying east and west portions of the county, which include Pflugerville, Manor, Hornsby Bend, and Jonestown, are no longer considered one of the kind of highest concentration levels of poverty in the county. We did add one new area, which is Oak Hill, off of West 290. Access to care continues to be a major barrier. In all the focus areas we identified, we had none of them had more than 40%, or excuse me, none of them had more than 55% of our enrolled population accessing care during the year. But what was interesting, what we discovered, is that this was uniform across the county in all the geographies that we looked at. So proximity to a clinic did not affect the amount of or the rate of enrollees that were accessing care. In fact, in all of our focus areas, they had the same average amount of visits per patient, 5 per patient. It didn't matter where they lived. Disease prevalence rates for our unhoused population is 1.5 to 2 times higher than our housed population. This is incredibly important information and ways that we have not looked at our population before. Again, this is about 9,000 patients who are presenting themselves to us in much sicker states than our average population, and they are utilizing services in much different ways. That being said, for our overall population, 40% of our patients are reported as having one chronic condition, and the average is 2.5 per patient. There is no real reliable benchmark to compare 40% of our patients versus 40% of another population, because HIPAA and other reasons, we only know what we know. I was able to find some CDC information, the National Health Interview Survey. For adults aged 18 to 64 with private insurance, about 16% are estimated to have chronic conditions. And those who are uninsured, it's 12%. So you can really understand the magnitude of what 40% means as far as how many people are presenting to us, and when they are presenting, they tend to be very sick. And finally, health equity, and this goes back to the work Matt did, is presenting where we're seeing inequities, higher prevalence rates are happening most significantly in East Central Austin and among our Black population, Black patient population. We can also say that demographics tend to have more of an impact than the geographic differences. So if we are more likely to see diseases present in a population based on race, ethnicity, than based on where they're located in the county. Next slide, please. This will be our agenda today. Next, I'm going to conduct a regional environmental scan. We're going to do a funnel. We're going to look at the big picture and then kind of drill down, get more focus. After that, we'll be looking at the work that Ashley's done, the Travis County poverty focus areas, enrollees in our network. and then we'll get into the health equity, burden of disease. And then Jesse will talk about people experiencing homelessness. Next slide, please. So just to kind of level set with the presentation that came before us and how does this work in conjunction with that. The demographic report was very much developed in alignment with the healthcare equity plan. That report, amongst its top identifications of needs, was for specialty care within our community. In alignment with that, we've done this improved analysis of chronic conditions, and we've also developed an equity index. So now that we know that need's there, we have data to really help pinpoint our efforts and what we're going to be doing in the community to address this. We also shared the same geospatial analysis, meaning we can bring data that was presented in that community health needs assessment and cross-reference them with this demographic report and vice versa. This information is going to inform and be used by the ongoing planning that's happening right now. And also, this is something we began 2 years ago in our last report. We're starting to improve benchmarks. We can start to measure the things we're doing, measure where we're putting our efforts, our money, our resources into, and see how those improvements are coming out. Transparency is obviously also important. We do not provide this level of data on our patient population anywhere else. This provides a very transparent, open view of where there are needs, where we can do and where we can do better. And finally, we also have a great level of details related to social determinants of health. We look into the education, the income, all sorts of factors within these high poverty areas. Next slide, please. Okay, so this will be a review from our November presentation for many of the folks here, but I know we also have some new members, so we wanted to make sure we brought some of this information back. This is the 5-county Austin Round Rock Metropolitan Statistical Area. This is an area that is created by the Office of Management and the federal government, Management and Budget and the federal government. They do it all across the country so that when they identify areas that kind of have common center and a lot of interconnectivity between each other, they can do statistical analysis on workforce, housing, those type of things. So a lot of times, if you hear references to the Austin area, Austin Round Rock area, they're usually talking about this geographic area. Next slide, please. So the table above displays the calculations that are used within this Austin Round Rock MSA to calculate income levels for subsidized housing. All these limits are based on the median family income within the 5-county MSA, which for 2022 was $110,000 for a family of 4. Just for a little comparison, the median income in Houston is about $90,000, and San Antonio is about $83,000. So as you may be aware, there's different housing units get different income limits. The lower the limit, the less income you're allowed to qualify to live in that unit. That first bullet point, as you can see, so if you are earning $27,750, you would be right at that 100% federal poverty level. You would qualify for our MAP program. Those folks are designated in that box with the red circle. So they would be in that 33,000 bracket, which HUD considers extremely low income. Next slide, please. So yeah, I just want to show you a couple more slides detailing the real estate market and income level changes that have been occurring regionally. So the black line in this graph represents the average home price that's been sold in the MSA over the last 32 years. And during that time, the average home price has increased nearly 600%. And over the last 10 years, the average prices have risen by 300,000. Again, this is the whole region, not just Austin or Travis County. Next slide, thank you. And so not surprisingly, as housing and affordability have gone up, so has the income levels across the region. These bars display the proportion of low-income residents from every county in the MSA, the change from 2015 to 2020. So as you can imagine, as that slice of the pie of the upper income keeps getting bigger, the lower income folks keep getting to be a smaller and smaller portion of it. Next slide, please. So the next question becomes, what can be done about all this? The rising housing markets and the cost of living are going up, so how can we help folks sustain living in this area? And one of the top answers, one of the solutions to this has been maintaining and building an adequate supply of subsidized low-income housing. Currently within the 5-county region, 80% of outlet subsidized housing is located in Travis County. And of that 80%, 92% of it's located in the city of Austin. So again, coming back to Austin, this is where they've got the funding, the resources that can back the subsidized housing. There is more plans on the way. The city of Austin, they adopted a strategic housing blueprint in 2017, and they have plans, although they've been slightly interrupted by COVID, to reach 60,000 new income restricted units by 2028. And it also fortunate for our patients and low income residents of the city, 68% of the existing and planned subsidized units are in districts 1, which is East Austin, Colony Park, District 2, which includes Dove Springs, 3, which includes East Riverside, Montopolis, and South Congress, and District 4, which includes Runberg, St. John's, and Windsor Park. So those areas where we have the most patients, where we're seeing the highest numbers of poverty, there are plans to keep bringing on more affordable units online. Next slide, please. So key findings for this area, the median income for a 4-member household in MSA is now $110,000. So that is about 4 times. The median income in our region is about 4 times the federal poverty level. These affordability and skyrocketing housing costs are now regional issues, and Austin remains the key access point for safety net services. I'm going to pause right now. I forgot to mention at the top, as we go through each of these sections, we're going to pause and answer any questions if you have them before we move on.
Thank you so much. Managers, does anyone have a question so far? Yes, Manager Jones.
Just a quick one. As you look at these numbers, is there any way to ascertain, are the folks who are driving up the population in Austin in terms of low income, those are along I-35, I think you said, are they coming from other places, or are they just Austin native? Trying to see if there's a migration into Austin because of, not for affordability, but because of resources that are driving some of the things that we see in terms of the structure.
Sure. We have done some looks into, we can, obviously to live in the city or the county does not require, you don't have to register. There are no citizens of Austin or Travis County. We, however, are fortunate as the healthcare district that we know a lot more about our population than those other entities. So we have done some looks into migration in and out of the county. We don't see, mostly what I've seen is people moving within the county, a few moving outside, but again, once they move or leave, we don't know if they just stop being enrolled, or we only catch them if something weird happened with the address, or they tried to continue their enrollment and we discover that they're outside the county. So we don't have any good data on who's coming from where at this point, beyond what we know within our own patients.
Manager Jones, one of the things that we did note Morale complaints, but one of the things that I did know is that folks who moved from.
Oh, here you go.
Folks who reside in the corridor and move tend to move within the corridor. So they stay within the area is what we're seeing. And that's why we're not necessarily seeing the deconcentration of poverty from that area. And we'll talk about it a little more in the rest of the presentation. Sure.
And with that, I will pass it to Ash.
One more
Oh,
question,
I'm sorry.
please. Yes, Manager Kitchen.
Yes, thank you. This is very helpful. My question relates to the something you mentioned about the overlap, or not overlap, but the intersection, I guess, between the MAP patients and the MFI levels. So I'm wondering if you have done analysis of our MAP patients and how many of them were housing challenged, because it looks to me like what's going on here is the MAP patients are at 30% MFIs, if I heard you correctly. And then when you look at what the city of Austin is working on, you know, in terms of available units, the 60,000 is 60,000 is not at 30% MFI. I don't
No,
think.
unfortunately, it starts at 80%
Right.
and then goes all the way down.
I just wonder if you, and it depends on what this data is, what we need to use this data for. And I'm sure you're well aware of this, but you can drill down with the city of Austin's information to find out where those are that are at 30% MFI.
Yes. So we don't have specific, our patients don't have to register whether they're receiving affordable housing or Section
Okay.
8 with us, but we do know where those, and we identified in our focus areas how many affordable housing units are in that area. What we are seeing as a trend within our patient population that is housed is low-income multifamily housing within the city, in the urban areas, and manufactured housing out in the beyond city limits.
Okay. I'd like to have more of a conversation offline about, I'm sure y'all are doing a lot of this coordination with the city, but I'd like to understand that better.
I'm not sure if it's, to your point, but yes, there is not enough housing in that 30% or below
Right.
that is reserved strictly, where our patients wouldn't have to compete with as many outside folks.
It's that level of MFI is really challenging for the city of Austin to fund. So it's this is very helpful. I'm just pointing it out, that as you already know, that the challenge and the need is much higher than these numbers would indicate. The other thing just to be aware of, and we can talk more offline, is that the number that's supposed to be met by 2028 is probably not the number that's relevant because it's not on target. The other thing to know is, and I'm probably telling you stuff you already know, but there's also all the affordable housing that's in the pipeline. So we know the number of subsidized housing units in these areas, but getting at the information about what's planned and zoned requires a more granular conversation with the city, which again, you may already be doing that. So thank you.
Absolutely.
This is very helpful.
Thank you. Anyone else? No. So yes, thank you.
Okay. Now I'd like to hand it off to Ashley.
Next slide, please. So as mentioned, we're going to sort of start with a broader look at poverty in Travis County first before looking more specifically at our enrolled population. So as of 2022, there are 23,655 families in poverty residing in Travis County. Over the next 5 years, it is projected that there will be an additional 1,799 families living below 100% of the federal poverty level, or FPL, within the county. This projected 7.6% increase in the number of families in poverty is expected to occur primarily in areas of existing and moderate poverty within the county. Currently, almost 3/4 of families in poverty in Travis County live along the I-35 corridor. In this central part of the county, 10% of families have incomes below 100% FPL, while Eastern Travis County has a lower total number of families in poverty. 8.2% of all families in the area are below 100% FPL. In Western Travis County, 2.9% of families are below 100% FPL. Slide, please. Thank you. So as it's been mentioned, like with previous demographic reports, we have decided to do a deeper look at the areas of the county where we expect there to be high and moderate concentrations of poverty as of 2027. These areas of poverty were determined by mapping data using a Jinks natural breaks classification method. And this method simply creates data ranges by grouping data so that they are as close in value to one another as is possible. And so utilizing this methodology, as shown in the map on the right, we were able to determine the areas of the county where we expect there to be moderately high and high concentrations of poverty in 5 years. Based off of those concentrations, we have grouped together census tracts to form 9 focus areas. And so these areas by no means represent the only areas of the county where there's families experiencing poverty. Rather, the 9 focus areas outlined in this report serve to provide insights into some of the areas of the county where we see those highest concentrations. In the last demographic report, as JP mentioned, we had 12 focus areas. For this report, those areas are no longer included, and that includes the Jonestown, Lago Vista area, Manor, Elgin, Pflugerville, and Hornsby Bend. And we also have the addition of Oak Hill for this report. There are still significant concentrations of poverty in those focus areas that were no longer included, but they were just outside of that threshold to be included for this report. The 9 focus areas for the 2022 demographic report, as shown in this graphic, include Colony Park, Del Valley, East Central Austin, North Central Austin, North Travis County, Northeast Austin, Oak Hill, South Austin, and Southeast Austin. For each focus area in this report, there is a 2-page spread that provides detailed information about the residents in the area. This, for example, is the first page of the North Central Austin focus area spread that covers the Runberg area of Austin. This is the second page for that focus area. Of note, this is the focus area that had the largest number of enrollees and patients out of all focus areas, as well as the highest total number of families in poverty and the second highest rate of families in poverty. Next slide, please. Thank you. And then this is the first page of the East Central Austin focus area spread. This is the focus area that had the highest percentage of families in poverty. And I'll use this in the following page to go over some of the data that was included for each focus area in this report. So starting in the upper left-hand corner, you'll note that we have an area overview that provides some basic information.
Gotta go back a few slides. There.
Thank you. That includes some basic information such as the total population, land area, and the census tracts that define the area. Below that is information on nearby central health providers, provider locations, and affordable housing and public transportation availability within the focus area. This information is then detailed in the map to the right, which contains the neighborhoods that make up the area, provider locations, locations of affordable housing developments, and bus routes. To the right of the map are the key takeaways for the focus area. And below the map and key takeaways are some social determinants of health data on income, housing, education, employment, families, and transportation. On the second page, we have demographic data. Starting at the top of the page, we have the demographics for all of Travis County. And then below that is demographics for all of those who resided within the focus area. Below that is demographics for Central Health's enrolled population within the focus area. Below the demographic data in the lower left-hand corner, we have utilization data for the enrolled population within the focus area. And then to the right of that, we have a summary of chronic condition-related data. Later in this presentation, Matt Richardson will touch on some of the specific data that is included in this section. Next slide, please. Okay. So shifting to enrollment, in this report, enrollees are defined as individuals who are enrolled in Central Health's Medical Access Program, or MAP, MAP Basic, local sliding fee scale subsidy programs that are reimbursed by Central Health, or the Central Health Assistance Program known as CHAP. In FY21, Central Health supported over 111,000 enrolled individuals. This was equivalent to 1 in 12 Travis County residents. This was a decrease in enrollment from what we presented in our last demographic report. And we attribute this mostly due to the impacts that COVID-19 had on enrollment and patient utilization. And since FY21, we have seen these figures start to recover towards pre-pandemic counts. In the map on the right shows where those enrolled in FY21 resided. The highlighted census tracts represent the areas that had the highest counts of enrollees. These 9 census tracts combined represent 20% of Central Health's enrolled population for the year. 94% of enrollees could be mapped to areas of Travis County, and 94% of those who could not be mapped reported experiencing homelessness at least once during the fiscal year. And Jesse Patton-Levine will touch more on this later in the presentation. A majority, 65%, of enrollees resided along the I-35 corridor during FY21. 30% of enrollees lived in East Travis County, and 5% lived in West Travis County. Between FY19 and FY21, Central Health saw the largest increases in enrollment in Eastern Travis County and the northern and southernmost portions of the I-35 corridor. Okay, next slide, please. Okay, and so this is breaking out some of the enrollee demographics for FY21. So you can see half of enrollees were between the ages of 18 and 44. A majority of enrollees spoke Spanish, with English being the second most spoken language. 8% of enrollees reported experiencing homelessness at least once during the fiscal year. Almost 54% of enrollees were female, and over 2/3 of enrollees were Hispanic or Latino. Next slide, please. Thank you. And then finally, we also include the Central Health Provider Network for Travis County in this report. And this data was as of November 2022, and it breaks down our provider locations into 11 different provider types. For this report, there were 159 providers locations listed, which is 13 more than what we had for the 2020 demographic report. And then finally, we also note that for those interested, they can visit the Central Health website to see our up-to-date provider network dashboard for current locations.
Next slide. I'm going to talk about the key findings from this section. So while we know that the increase in families in poverty overall is kind of plateauing or not growing as fast as it was at one time, in the areas that we've identified, these low-income focus areas, it's actually growing at a rate of 4 times faster than the rest of the county. So low-income areas, families in poverty are going up at a significant clip. Poverty and enrollment do not always align. So if you put a map of where the low income population is next to our enrolled population. They are not going to lump together. Outreach efforts, other factors that where we choose to really concentrate our work can affect how many people we get into our programs. Spanish is spoken by 46% of our of the focus area residents. That's the total population in these focus areas, which is double the county. We do have a majority Latino enrollees in our areas, and the area, the highest percentage of Black enrollees exists in East Central Austin. As expected, the median income in these areas is significantly less, $34,000 than the county overall. Almost half adults do not have a high school diploma, and people who live within these focus areas are much less likely to have access to a vehicle. Next slide, please. We wanted to show you this slide to reinforce what we spoke about earlier, Ashley and I, as far as the changes and movements from the last demographic report. The map in the center represents the updated areas with the highest counts of poverty. What you can see there is where things have changed since the 2020 report. Starting in the top right, you see Pflugerville, Manor, Elgin, and Hornsby Bend are no longer on this map. Del Valley has gone from having 3 focus areas to now 1, or excuse me, census tracts within its focus area to 1, so it's gotten smaller. And Leander, Lago Vista are no longer on the map either. Next slide, please. And finally, we want to go through some key findings respect to each of the 9 focus areas. In Colony Park, we have 1 in 4 residents enrolled. This is the highest among any of our focus areas. We also have half the households containing children below the age of 18, which is also the highest rate. Colony Park is an area, the neighborhood itself, that is experiencing some gentrification as more and more homeowners spill out into these areas. So most of our patients who reside in the Colony Park area actually live in these large manufactured housing communities outside of the traditional Colony Park community. Del Valley has the lowest poverty rate in total residents in poverty compared to all the other focus areas. In perspective, it has about 10% of the families in poverty that we're seeing in Runberg. It has a higher than expected enrollment rate based on that poverty. Like I said before, when you look at the maps of poverty enrollment, they don't match up. Del Valley is one of those areas you would see it pop up with high enrollment, but not so much with the poverty. It is also the only focus area located east of Toll 130. Regarding East Central Austin, this is, Ashley mentioned, the highest percentage of families in poverty. It's 26%. We have a lower, so this is kind of the converse to Del Valley. Based on that high percentage of poverty, we'd actually expect to have more enrollees in East Austin than we do. It also, in East Austin, we saw that 1 in every 20 of our patients received all their care in the ED, which is the highest of anywhere we looked at. Next slide, please. North Central Austin. So this is the focus area containing Runberg, and there is really no other area that can compare in the size, the total of families in poverty, the total enrollees, and the total patients. At $50,000 a year, this area, Runberg, has the lowest median income of any of the areas we looked at. And although we enrolled 11,800 people there into our programs, 5,200 of them never received services. North Travis County, it's an interesting geographic area. It's kind of tucked to the south of Pflugerville, to the west of Manor, and north of Austin. So most of it is in unincorporated areas. Primarily to the eastern portion of this, our low-income population is in unincorporated areas located, manufactured housing communities in unincorporated areas. In the west, they tend to be in low-income multifamily housing in areas such as Wells Branch. Also, interestingly, this area had the highest increase in families in poverty of any of our focus areas over the last 2 years. And 12% of the residents in this area speak a language other than Spanish or English. Northeast Austin, this is the St. John's neighborhood right across I-35 from Runberg. We kind of see enrollment as we would expect in a high poverty area. There's 3 times the rate of Spanish speakers in this area compared to the rest of the county. And they also have the second highest total amount of subsidized affordable housing of any of the focus areas. Next slide, please. Oak Hill, this is our new focus area, the only one we added this year. It's interesting in this, when we see the counts, it has similar poverty numbers to Del Valley, but it has only half the enrollment of Del Valley. So they both have about 250 families in poverty, but in Oak Hill, we enrolled 822 people. In Del Valley, we've enrolled about 1,800 people. And while the total population over the last 2 years increased by just 4%, the families in poverty in Oak Hill increased by 21%. In South Austin, this is Dove Springs area. It has the highest Latino enrollment of any of our focus areas. It is the highest rate of adult residents without a diploma. And interestingly, it is the lowest number of patients who use the ED exclusively. It's the only focus area when we looked at their top 5 locations of visits that didn't include a hospital. It's also the area that had the highest rate of people accessing specialty care. Finally, Southeast Austin. This area experienced the largest rate decrease in enrollment over the last 2 years. It has the highest utilization rate. So even though we're losing enrollees here, the ones we do capture are going at a higher rate than anywhere else. It's the second lowest median income area, $51,000 a year. Next slide. And with that, if you have any questions specific to this section, we'd be happy to answer them.
No, it doesn't look like anyone has a question.
Okay. Thank you. With that, we're going to pass it on to our colleagues.
Yeah, I have literally thousands of questions, but I'm not going to ask them now. I guess my question is, at some time, could we have a work session where we could go through and dig down deep into this? Because I think a lot of this information is very valid. And in terms of planning, we need to monitor some of these things. So if we could, I just put that on the board to consider.
Thank you. With that, I'm passing on to Matt and Jesse.
Okay, thank you, JP. Good afternoon. My name is Matt Richardson, and I'm an analyst here at Central Health, and it's a pleasure to come back to the Strategic Planning Subcommittee to present our findings. Today, I'll be discussing health equity and burdens of disease in enrollees due to chronic conditions. Next slide, please. So chronic conditions are widespread and negatively impact the health of our community. According to Austin Public Health data from 2021, chronic conditions account for 3 out of every 5 deaths in Travis County residents. Persons living with these conditions often face challenges in managing their medical conditions, visiting specialists, and maintaining their health through medications and lifestyle changes. And as JP mentioned, our analysis found that 40% of the Central Health patient population, that's 38,647 people, had a diagnosis of at least one of these chronic conditions. And of those with a chronic condition diagnosis, the average member had 2.5 of these conditions to manage. So this chart shows the rates of clinically diagnosed disease per 1,000 persons by condition. for the 9 chronic conditions in descending order. These conditions were selected based on the impact on the population and to be consistent with the FY19 demographic report. CVD at the bottom refers to cardiovascular disease, which includes stroke, and COPD refers to chronic obstructive pulmonary disorders. All of the rates have been age adjusted to allow for ease of comparison. So as you can see, the top 4 conditions were cardiovascular disease, hypertension, behavioral health, and diabetes. The black line represents the cumulative percentage moving left to right. So CVD diagnoses were about 30% of the total. Adding in hypertension gets you up to about 55%. Behavioral health gets you to around 70, then the inclusion of diabetes gets you a little bit over the 80% mark. To put these numbers in perspective, about 1 in 4 members of the central health population had a CVD or hypertension diagnosis, and about 1 in 7 had a diagnosis of diabetes or behavioral health. It's important to note that both these counts and the rates are important because the counts tell you about the burden of disease in the community and allow you to plan for system capacity necessary to address those needs. So how many providers do you need and what kinds of specialties do you need? Rates then tell you about the impact on specific subgroups and allow you for comparison across populations of different sizes. Which populations are disproportionately impacted? Are there pockets of need within these overall populations? In the demographic report, both counts and rates are reported both at the county level and at the focus area level. These were also analyzed by age, race, and ethnicity, and we'll look at the top 4 chronic conditions in the slides that follow. However, I'd like to note that all of these conditions are important and have very real impacts for our enrollees. Accordingly, the full report has detailed summaries for all 9 conditions. Next slide, please. So this is an example of the information provided in the chronic condition pages of the report. Here we see the spread for the most prevalent chronic condition, cardiovascular disease. So cardiovascular disease is the leading cause of death globally, and more than 4 out of 5 CVD deaths are due to heart attacks and strokes. 1/3 of these deaths will occur prematurely, that is in people under 70 years of age. There's a lot here, so let's take a look around. It's kind of a guided tour. I know it's probably hard to read on the screen. So we'll be looking at several of these elements in more detail in the slides that follow. So at the top left, you have the overall unduplicated count of central health patients diagnosed with cardiovascular disease as 24,240 people. The map then at the right shows you where those patients live in the county by census tract, with darker areas indicating more patients. This tells us about how the burden of cardiovascular disease is distributed and where access to cardiology is most needed. We can also see the top 5 locations where patients sought care just underneath the overall summary on the left. The most encounters occurred at CUC North Central, followed by the Southeast Health and Wellness Center, then the Dell Seton Medical Center and Seton Medical Center Austin, and finally CUC South Austin. Below that, we have a demographic breakdown by age, primary language, sex, and race ethnicity, and we can see that most of the patients with cardiovascular disease were 45 to 64 years old, spoke Spanish or English, and were overwhelmingly Latino. However, it's important to note that the percentage of Latino patients with CVD is basically the same as their percentage in the central health population. So to see which groups are disproportionately impacted, that is the groups with more disease than we would have expected given their proportion of the population, we look at what we're calling the prevalence equity index at the bottom. So essentially this is just a ratio of the disease in each group to the rate of disease overall. So a value of 1.0 would mean that the observed and the expected rates are the same. For example, a group that is 10% of the population that also has 10% of the disease that we're looking at. Values less than 1 would mean that there was less disease than expected, and values greater than 1 would mean that there was more disease than we expected. And the darker the box, the greater the disparity. And we've circled groups in yellow that had statistically significant differences that were unlikely to occur due to chance. These equity indices are also provided by focus area in the focus area spreads that Ashley showed you earlier. And lastly, we have a summary bubble with some key take-home findings in the pink there on the page. So let's zoom in on the next slide to consider this information in detail. Next slide, please. Zooming in, you can better see the utilization, equity, and summary information we just discussed. And compared to the overall central health population in Travis County, we found that Black enrollees were 30% more likely to have a cardiovascular disease diagnosis. Similarly, patients living in East Central Austin and Southeast Austin were 10% more likely to have had that diagnosis, although only the East Central Austin finding was statistically significant. Identifying those at highest risk for these diseases ensuring they receive appropriate treatment can help prevent premature deaths. And so this equity information may be helpful in targeting both geographically and demographically community engagement efforts, health education, screening, chronic disease self-management programs, and access to cardiologists. Next slide, please. The second most prevalent chronic condition was hypertension. Hypertension can have a range of adverse health effects, putting extra strain on the blood vessels, heart, and other organs such as the brain, kidneys, and eyes. Persistent high blood pressure can increase your risk for a number of serious and potentially life-threatening conditions like the heart disease, heart attacks, and stroke that we just talked about. There were 20,833 unduplicated individuals with a hypertension diagnosis. The utilization pattern we can see is very similar to what we saw for cardiovascular disease. Again, we see demographic and geographic disparities, and compared to the overall central health population in Travis County, Black enrollees were again 40% more likely to have had a hypertension diagnosis, with patients in East Central Austin, South Austin, and Southeast Austin having a slightly higher risk of having hypertension, but none of those differences were statistically significant. However, patients in Oak Hill did have a statistically significant 10% lower risk of hypertension. Next slide, please. Behavioral health includes both mental health and substance use disorders, and without treatment, the consequences of mental illness for the individual and society are staggering. Untreated mental health conditions can result in unnecessary disability, unemployment, substance abuse, homelessness, inappropriate incarceration, poor quality of life, and suicide. Additionally, people with behavioral health conditions are at greater risk of developing other chronic diseases such as cardiovascular disease and diabetes. There were 16,475 unduplicated individuals with a behavioral health diagnosis. The utilization pattern is different. The Southeast Health and Wellness Center provided the most encounters, followed by CUC North Central, Del Seton Medical Center, Lone Star Circle of Care's Ben White Health Clinic, and finally CUC South Austin. Demographically, compared to the overall central health population, white enrollees were 100% more likely to have had a behavioral health diagnosis, and Black enrollees were 50% more likely. However, neither difference was statistically significant, and this reflects the underlying variability among the groups, where no demographic difference was big enough to be so far above the average that it crossed the threshold for statistical significance. Again, we see that East Central Austin had a statistically significant 30% excess of behavioral health diagnoses. Next slide, please. Diabetes can lead to heart disease, stroke, kidney failure, blindness, and lower limb amputations. Recent research has also shown a connection between diabetes and dementia, hearing loss, and some forms of cancer. Diabetes also increases the risk of early death, and diabetes-related complications can lower quality of life. In fiscal year 21, diabetes was the fourth most prevalent chronic disease in the central health population in Travis County, affecting 1 in 7 enrollees, or 12,207 people. Here we see a similar utilization pattern to cardiovascular disease and hypertension, with patients visiting CUC North Central, the Southeast Health and Wellness Center, Del Seton Medical Center, CUC South Austin, and Seton Medical Center Austin. Encounters for diabetes at these top 5 locations were roughly half the number of encounters for cardiovascular disease. In terms of equity, compared to the overall central health population, Latino enrollees were 10% more likely to have had a diabetes diagnosis. Geographically, patients in most of the focus areas had a slightly higher risk of having diabetes, while residents of South Austin had a 30% increased risk. However, none of these differences reached statistical significance. All of this information and a lot more is provided in the 9 chronic condition spreads in the demographic report and the supporting appendix. Next slide, please. We also looked at these rates over time since our last report. Compared to FY19, the prevalence of most of these conditions was generally about the same as it is now, with some notable exceptions. Behavioral health diagnoses increased 9.8%, renal failure diagnoses increased 21.9%, but from a small number. Heart failure diagnoses decreased 9%, and chronic obstructive pulmonary disease decreased 6%. But it's really difficult to draw a trend from any 2 data points, especially when a global pandemic occurs in between the 2 data points. So these changes may well be due to variations in diagnosis, reporting, utilization, testing. So we'll continue to monitor chronic disease prevalence over time to get a better understanding of how these trends are evolving. Next slide. So finally, let's take a look at our key takeaways. Number 1, the most prevalent chronic conditions for the central health population in fiscal year 21 were cardiovascular disease, hypertension, behavioral health, and diabetes. And at the focus area level, Ashley showed us the top 3 condition rankings varied slightly among these 4. There really weren't that many surprises. The average patient had 2.5 chronic conditions. 40% of patients had at least 1. There were statistically significant higher chronic condition prevalence rates for Black enrollees and persons living in East Central Austin. Rates for the unhoused were significantly higher, which Jesse is going to discuss shortly. And demographic differences had a greater impact on disease prevalence than geographic differences. So thank you for your time and attention. Are there any questions specific to chronic diseases?
Well, it's really not a question, more of a comment. 'Cause unfortunately, this is not surprising. And yet there's a lot, I'm just thinking about, we just had a presentation previously about our health equity strategic plan, all these findings, and the thinking of how we want to build out our specialty care, but yet we need to hone down on our root causes of the issues leading us to this problem. Like thinking about the most prominent health chronic conditions, you had cardiovascular, but our average within our community, with our population is 2.5 chronic diseases. Yet if they have hypertension and diabetes, that could lead cardiovascular disease and can lead to other diseases as well. So there needs a lot of I don't know if it's planning, more of a structured effort to really address these root causes and how we can work as a community as a whole, because Central Health obviously cannot tackle these issues. There are causes of, like we talked, we're going to be discussing homelessness. We talked about housing and access to healthy food and nutrition, addressing these food deserts that we have. So, and that all would help alleviate some of these root cause issues. But unfortunately, equities will continue to exist if we did not really, if we didn't collaboratively work to address these issues. So it's just more of a comment, really not a question. I know you've all worked very hard and tirelessly, and unfortunately we see this all across different communities who are vulnerable and underserved throughout the state of Texas, who has the highest rate of uninsured. But yet overall, thank you for your efforts, and hopefully one day we'll have better stats. Thanks.
Thank you for that.
Yes, Manager Jones.
Just one question. Very good. Appreciate it. Years ago, when public health was going through accreditation, we had a series of town hall meetings around the county in particular areas. And we took the data that was present at that time into those communities. And we talked to them specifically about what they occurred. And what we found is what you're identifying here, is that there's an overlap between homelessness, housing, and these chronic diseases, as well as access to healthcare and the like.
Sure.
I say all that to say that as part of an overall effort, I think we need to look at, from a community-wide approach, what collaborative efforts can be undertaken to address that. The city and the county just recently formed a public health commission. That commission could perhaps be a process by which all of the players could come together to start looking in terms of the geographic, the demographics, as well as the epidemiological data that we see. And in those particular areas where there like collaborative efforts can be to address that data. So I just make that as a comment so that we can look at that, make it as part of our planning effort.
Yes, thank you.
I'm going to be leaving at 3. So.
Okay, yes, thank you very much. Manager Kitchen.
Quick question. So the behavioral health, and I don't need the answer right now, but the mental health and substance abuse, that data available?
Yes, so we have it at the ICD-10 diagnosis code levels. We know if that is a substance use diagnosis versus something like severe mental illness, depression, anxiety, things like that. That could be broken out. It's not broken out in this report. That would be a separate special request. I defer to Sarita.
Yeah, I don't need to ask for that now. I just want to know if that available.
Yes, ma'am.
Then the second quick question is, well, it's just more of an question. Yeah. So, and it may require more of a conversation later, but it strikes me that the behavioral health diagnosis may be, but can you speak to that for a minute?
I agree. I 100% think that all of these are very conservative estimates of what's actually going on. they're sick.
So
I might let Jessie weigh in on that. I know she's looked at it a little bit. Sure. And there's a lot of stigma specific around substance use and mental illness.
Yeah. So how we defined someone having a chronic condition is that we looked to see if they had any diagnosis within our utilization data in the previous 3 years. So that right there gives you an automatic skew. If someone has that condition and we didn't treat them, and also if they came in for treatment and that wasn't coded, we're missing those individuals. So there's definitely an underestimation. I follow what Matt said, it's conservative. By how much, it's hard to say. It's hard to really look at a comparison population to understand maybe what that magnitude could be.
Yeah, and there's sick and sick enough to go to the doctor and sick enough for the doctor to run the right test and get that, like there's that disease pyramid. We're just getting the little teeny tiny tippy top of it. And I echo your concern.
Yeah, the reason I ask that is just because we've got different, I'm sorry, I promise I'll get this figured out. So the reason I'm asking is just because we're saying that here's our prevalence. And we've got behavioral health, I think 3rd or 4th.
Mhm.
But I'm just wondering if that's really, we just need to caveat that because it may be disproportionately diagnosed as related to the other conditions and as related to certain demographics.
It well could be number one. We just don't have that information
Okay.
if we don't have the diagnosis code. But I definitely share your concern there.
Okay,
That's very real.
thank you.
Any other questions about chronic diseases? I know it's a fun-filled, exciting topic that gets everybody all riled up. No? Okay. Well, then with that, I'll pass along to Jessie Patton Levine to talk about persons experiencing homelessness.
Great.
Thank you.
Thank you, Matt, and thank you all for having us here to present. You can go to the next slide. So homelessness is defined as lacking a regular nighttime residence or having a primary nighttime residence that is temporary or not designed for sleeping. On a single day in July of 2022, over 4,000 people experienced homelessness here in Austin Travis County. This is the echo point in time count that includes unsheltered and sheltered individuals living in temporary shelters and transitional housing. In FY 2021, over 13,000 individuals were served by our local homelessness response system, with needs ranging from minimal housing assistance to more intensive services like permanent supportive housing. Next slide. Among the Central Health enrolled population, over 9,000 individuals experienced homelessness in 2021, and this represents 8% of our overall enrolled population that year. Unhoused includes unsheltered individuals and sheltered individuals living in temporary or transitional housing. 56% of our members experiencing homelessness did not have a known or valid physical address, and therefore represented the majority of individuals who could not be mapped and included in the geographic analysis presented earlier by Ashley and also Matt. Next slide. So this is a look at the demographics of our unhoused enrollees, and they're a little bit different from our overall enrolled population. These folks are less likely to be under the age of 18 or over the age of 65. They are majority male at 73% and majority English speaking at 90%. No single race ethnicity category comprised a majority of the population. Persons who reported as other race made up the largest proportion at 32%, followed by white individuals at 26%. I just want to point out that compared to the overall population, rates of homelessness are disproportionately higher among those identifying as other, white, or Black. Next slide, please. So here is a side-by-side comparison view. So you can look at that overall enrollee demographics compared to our unhoused enrollees. And you can really see those differences visually in age, language, sex, and race ethnicity categories. Next slide. So close to 60% of our members experiencing homelessness had at least one chronic condition, compared to 40% among all enrollees. This population also had on average a higher number of chronic conditions at 3.2 per member compared to 2.5. Next slide. The top chronic conditions among members experiencing homelessness include behavioral health, cardiovascular disease, hypertension, and diabetes. These are the same top 4 conditions as we saw in our overall population, with the exception that behavioral health moved from the number 3 spot to the number 1, surpassing cardiovascular disease and hypertension. And diabetes remains in the 4th position. Next slide. So using the prevalence equity index that Matt went over for his section on chronic disease, we looked at that index for our unhoused members as well. So we compared rates of disease among our unhoused enrollees in reference to our overall enrolled population. So again, a number higher than 1 shows excessive burden, and a number below 1 is going to show less. I've circled the conditions with statistically significant differences on the slide in red and green. We found that among members experiencing homelessness, behavioral health and renal failure rates are twice what we would expect when compared to the overall population. COPD rates are also higher, in excess of 50% when compared to the overall population. And while diabetes is a top chronic condition in this population, the rates of disease are lower than expected when we compare it to the overall population. Next slide. Members experiencing homelessness had over 28,000 encounters in fiscal year 2021. 12% of those encounters did involve Austin Travis County EMS, which is notable compared to the other focus areas that we presented. Next slide. So when comparing the healthcare utilization between our unhoused enrollees and the overall enrolled population, we see some similarities and differences. Both population groups saw 56% of enrollees use services in fiscal year 21. And of those individuals that utilized, 80 to 83% visited a primary care physician during the year. Unhoused utilizers, however, had a higher average number of encounters per year, with 6 compared to 5 in the overall population. 13.6% of unhoused utilizers received specialty care services at an FQHC, compared to 17% in the overall population. And 10%, or 1 in 10 of unhoused utilizers, had all of their encounters occur at an emergency department, compared to 3%, or 1 in 32 among the overall population. Next slide. This slide here shows the top 10 care locations visited by members experiencing homelessness. The Del Seton Medical Center at UT is in the top position there with over 5,000 encounters. Austin Travis County EMS comes in at number 2 with over 3,500 encounters. And the Central Health Southeast Health and Wellness Clinic is at number 3 with over 3,000 encounters. In this list of top 10 locations, we also see Seton Medical Center Austin come in at number 4 on this list, and Seton Northwest Medical Center is number 9. I did want to note that 2 of the top clinics on this list, specifically this Community Care Connections Clinic and the Community Care Arch Clinic, encourage our members experiencing homelessness to seek care on a walk-in basis and without need of referral. Next slide. So just a brief summary of the key findings of this section. Again, 8% of our enrolled population reported experiencing homelessness in 2021. And I think what's really key here is that due to the challenges with geography and address, they are not fully represented in the focus area analysis presented earlier. We also see high rates of chronic conditions in this population, so specifically behavioral health, renal failure, and respiratory conditions like COPD and asthma are higher among our unhoused members than the overall population. So 56% of these members did utilize healthcare services at least once in fiscal year 21, and 80% of those utilizers had at least 1 primary care encounter with a primary care physician. However, 1 in 10 did visit only an emergency room. And this population, we just see a high volume of encounters, encounters at hospitals and with emergency services. Next slide.
Just a quick question. you have data about hospital admissions? I see this data.
I'm gonna, let's read it.
So we didn't include admissions report, and we're looking at but we'll include it. Rather than just. Is that how instead of eligible? It is.
I know it's mine. Okay. So do you know why the UT Dell clinic was the highest? Is it in terms of hours, location? Or do they have, I know they have certain programs. So I'm just wondering, is there an intervention targeted for this specific population? That's why the utilization for the care at those clinics is higher in comparison to community care. So that's cool.
Sorry, so it's the hospital. So the Seton, Dell Seton Medical Center UT hospital, and that most likely speaks to their ED utilization.
So going back, there was actually a case a few years back in Dallas at Parkland Hospital for a similar population where they looked at, I think one of the high utilizers, frequent visitors to these clinics was a hypertensive patient. And it turned out like this individual was costing the system hundreds of thousands of dollars, which could have been managed by just giving them their medication and access to their medication. So that's something also for us as we're planning this health equity plan to be cognizant and aware of. We could have prevented these visits by simply thinking outside of the box. How can they access their much needed medication?
Absolutely. And we actually are currently doing that work in this space we have a transitions of care team that is growing, that is being built out. And as we're working with our consultants at Guidehouse, they're helping guide this work as well. But we understand that, to prevent these occurrences, these avoidable admissions, if you will, or ED admissions, we have to be proactive.
Thank you.
I don't believe there are further questions.
Great. Then with that, we'll wrap it up with our key conclusions and then follow up from this. So some of the key takeaways from the report, to reiterate, is anyone looking at a news feed can tell you that affordability and a high cost of living is impacting folks nationally, not just here. But it's important to keep in mind that here locally, that this issue is more than a Travis County, Austin issue. It impacts surrounding counties as well, including Caldwell, Hayes, Bastrop, and Williamson. Austin is a key access point for healthcare, affordable housing, public transportation, and social services. And we hypothesize that it might be one reason that those folks who are at that lower end of the socioeconomic scale tend to stay here in that area. Families in poverty are becoming, well, they have been and will continue to be for, as long as we've seen the projections from this report, concentrated near that I-35 corridor. Access to care continues to be a barrier to health, regardless of the proximity to care. So as we saw in the report, even though there are clinics in close by in those areas in North Central Austin, utilization is low among those residents. Disease prevalence for unhoused populations is 1.5 to 2.5 times higher than housed. 40% of patients had at least one chronic condition, and the average is 2.5 per patient. And health equity issues most significantly impacted folks in East Central Austin, and our Black enrollees, or Black patients, and I make that distinction because these are folks who've had who've had a clinical service, were also disproportionately impacted. But we also noted that those demographic differences had more of an impact than the geographical differences among our MAP and MAP basic population. And so where do we go from here? The next step is to finalize and release the demographic reports later this month, to coordinate a media release, public awareness, and have community conversations so that people are aware of our population, the attributes of our population, and to help them understand how they can partner with Central Health to help change some of the outcomes that we see. Share findings with partners and community stakeholders, and support the ongoing systems planning work that we heard earlier about from our Guidehouse.
Oh, yes, Manager Kitchen.
There will be 2 years.
Perhaps we could consider a supplemental report sometime with the hospital admissions data. I don't know what all entailed. I'm just saying, we can talk later, but maybe that could be.
Sure.
I don't know how hard.
Yes.
This committee does receive an annual utilization report, so we can go back and look at the timing of that. And we're working with the data team to make sure we got good data sets, but we can certainly bring that discussion up during that annual utilization.
That's great. Thank you.
And so and we had admission data from one hospital system, and we didn't want to, there are 2 other big systems in our community. We didn't want to just have it the data skew towards that one system for that inpatient care.
Well, there may be a longer conversation that needs to be had.
Sure.
The point I'm just making, hospital admissions.
Yes.
Information is.
And we continuously look at that internally.
We can bring it back.
Well,
It's also important.
sure, of course.
We can have a longer conversation.
Thank you.
After that. Thank you. But I hear what you're saying.
Thank you so much. That was wonderful. I think we all learned a lot. Does anybody have any last questions? No. So thank you very much for bringing this to us, and it will be online for the community at the end of January. Great. Thank you. Okay, perfect. All righty. So number 4, we're going to receive a year-end update on communications, community engagement, and community outreach. And Ted Burton, Ivan Davila, Isela Guerra, and Anastasia Sims Mitchell will be presenting. Yes, yes.
Hi, everybody. Good to see you. My name is Ted Burton. I'm Vice President of Communications, and I'm excited to share with you a report regarding our 2022 communications, community engagement, and outreach activities. The demographic report and the operational and financial sustainability plan really tee up the work of this department beautifully and really sets a course for us for 2023. And Manager Kitchen, I also want to let you know that you'd asked questions. I was trying to join the conversation, but my camera wouldn't work, regarding community conversations about the health equity plan. We did host 6 community conversations in June and July at locations, including here at Cesar Chavez, throughout Travis County. And we have a pretty robust schedule for this spring and summer regarding the health equity plan, the demographic report, and much more. And I look forward to sharing that with you during your board orientation. I think it's next week. Yeah, thank you so much. So before I get started, I would like to reintroduce, for many people in the room, but to the Dream Team. It really is my honor and pleasure to work with such a passionate group of tireless, fun, and not camera shy people. You can see the next slide. So this is the Dream Team, and I would like to introduce those that are in the room, starting with my colleagues here who will be presenting today. Yvonne Davila, who is our Director of Communications and Community Engagement. Isela Guerra, who just celebrated her 14th anniversary. I've been trained not to say she's an old timer. She's a long timer at Central Health. She's our Outreach Supervisor. And Anastasia Sims, who is our Multimedia Content Supervisor, responsible for much of the stuff that you see out in public. And then in the back of the room, we have almost everybody here. We have Aida Serta-Prezek, who is our Community Outreach Specialist. Aida, can you wave? We have Christian Nelson, who is a Program Manager, and he is responsible for our Community Health Champions program. We have Camila Rodriguez, who is our expert graphic designer. She makes things that we produce look pretty. We have Yesenia Ramos, who is another one of our Community Engagement Program Managers. And I think we have, over here, we have Edwin Evans, who he is literally the Edwin of all trades. He does communications and outreach. And we have Mike McKinnon, another long timer, not old timer. He may have been in longer than Isela, but Mike is our Senior Communications Manager, and he pushes buttons and makes things happen. So I often just yell from my office, Mike, and Mike comes and saves the day. So with that, we'll get started and talk about some of our activities from the previous year. I wanted to start by saying, next slide, that we have a strategic communications plan. This is the wrong. We have a strategic communications plan that we evolve every year. It's the slide with the plan on it. And this slide, which is going to show up in a second. Is it on? Oh, Brianna. Okay, so. I agree. There we go. So this is our strategic communications plan that we evolve every year. The work that we do supports the organization, of course, but we have our own goals and objectives for the communications department. Our overarching goal is to increase awareness of Central Health, its programs, its services, and the value that the organization brings to the community. We have 3 pillars for our communications department, and they are trust, transparency, and accountability. The main objectives of our communications plan is to help Travis County residents with limited incomes get and stay connected to care and coverage, and to get Travis County residents involved in the work of the organization. And so now we're going to dive into some of the accomplishments from the past year, beginning with our overarching goal number 1, which is to increase awareness of Central Health, its programs, services, and the value the organization brings to the community. I want to turn it over to Anastasia to talk about our earned media and social media activities. Anastasia.
Okay, so we leverage a strong social media presence by posting dynamic, relevant informational content for our users, by targeting specific areas, and by boosting posts. This year, our social posts reached 22.1 million people. This was on Facebook, Twitter, and Instagram. And unlike media relations, which I'm going to talk about in the next slide, social media gives us the opportunity to engage and listen to our audience. So we can talk to them about MAP enrollment, they can ask us questions, and we can direct them to where they need to go. Also, I think that social media gives us personality. If you go to our Instagram page, sometimes you'll see us dancing, but we're pointing you back to healthcare. In addition, it gives us, actually, next slide. So earned media. When it comes to earned media, we employ media relations strategies. Am I not being heard? We employ media relations strategies to push our stories to local media outlets. How do we do this? We generate story ideas in partnership with other departments like healthcare delivery, the office of the CEO, and everything. There's a lot of things happening at Central Health. So we generate story ideas and we create press releases and then we pitch those stories to the media. Once the media says they want to do the story, we package the story. So we set up interviews, videography, or anything else needed for the story. So media relations also increases our visibility within the community and it gives us credibility. It conveys to our audience that we are trustworthy, authentic, and transparent. So last year, you can go back to the previous slide, sorry. Yes, so last year our top media outlets were the Austin American Statesman and KUT, and our top performing story was about the groundbreakings in Eastern Travis County. So we reached 900.3 million people for an advertising value equivalency of 22.4 million. So that means that 903, I'm a communications professional, not a mathematician. 903.6 million people either heard or saw something about Central Health. And then advertising value equivalency just means that if we were to purchase this media, it would have cost us 22.4 million.
And that number probably sounds really large, but keep in mind it's impressions. So you can be responsible for 30 impressions. I'm there at my website, my computer's clicking on stories over and over, so I'm responsible for several hundred possibly. But just so you know, it may sound like a lot, but it really is significant and important to understand what an impression is.
Next slide. So video production, and rather than talk about this, I'm gonna show a sizzle reel, and I wanna give credit to our communications and outreach specialist, Edwin Evans, who is our main videographer and really responsible for this reel. But we create a variety of video content from IG Reels to YouTube to even producing live events like, kind of like this one. So, yeah, go ahead.
What we need is a more comprehensive system of healthcare out in Eastern Travis County. And today shows that we are moving in that direction. And it is huge because this was brought forward by the community, it's for the community, and it's of the community.
Historically, Central Health moved care by way of contractual relationships. By Central Health being able to hire physicians and build healthcare infrastructure, we could more directly affect care and adapt that care to the communities that we know best and to whom we serve.
A lot of times patients don't have anywhere to go, so that's why the need for a specialty clinic is so important, especially for our at-risk population here in Austin.
This is the site where we are going to talk about how to eat healthy, on a budget, under 500 calories, with as few ingredients as possible to have good vibes.
My motivation for my work comes from a core belief that every life is of equal worth and that everyone deserves the right to experience and live the healthiest life possible. I love working here at Central Health because it gives me a unique opportunity to not only take care of patients, but also optimize the system and care for them.
And is it about a building? Yes, but it's also about what happens within the four walls of those buildings. And the programs that we bring about and the health experience that we can overcome and the equity that we can achieve. So this means so much more than just a building on a piece of land. This is big. And so we want to thank everybody for coming out and helping us celebrate and recognize this. Thank you.
So thank you, and don't forget to follow us on social media. I think I'm passing it to you.
Oh, okay. Next slide. Oh, I'll wait for the slide. Good afternoon, everyone. My name is Isela Guerra, Community Outreach Manager here at Central Health, and I'm going to talk about how we continue to try to reach our goal through our objective of helping Travis County residents with limited income get and stay connected to care and coverage. Next slide. So the grassroots outreach activities that our team conducts, we are a small and nimble team, but we try to get out there in front of residents and meet them where they're at. That means that we are out canvassing neighborhoods, hard to reach neighborhoods, in some cases going door to door, tabling at community events and resource fairs, and reaching people that way and presenting our information to community partners and helping, and they help us reach even more people, especially those partners that serve similar populations. Here are some of the numbers that we achieved in this last fiscal year, 2022. The activities, 260 activities we attended include those things like the health fairs, the canvassing, and tabling. The number of people we reached, again, this number, 15,500 plus people. These are people that we spoke to, practically people that we touched with the information, right, on MAP, on the programs going on at our health and wellness centers, and also helping people connect to basic needs resources. We know that a lot of times healthcare is on their mind, but it may not be top of mind if they need food, if their housing is unstable. So we definitely try to connect them with additional resources. Last year, we also employed what we call a lead generation strategy, and that can be very comparable to, to a sales lead. So we were out in the community talking to people, and when we talked to them, we tried to do a high-level screening in a very conversational way to see if they might be someone who could qualify for our program. And if so, we collect their information, then call them back later where we can more privately speak about their needs. And then many times, someone like Aida, our community outreach specialist, is helping them navigate either getting enrolled into MAP through the online application, doing a warm transfer to our call center and making sure that they get through, and also connecting them to those other basic needs resources that they might need. So last year, we collected over 1,000 leads, 1,478 leads, and those are all people that we did talk to in a more extensive fashion. And then of those people, 429, that's the number of people we were actually able to connect through those conversations to our call center to get them enrolled or to those other services that they need. And so this year we'll continue to grow that hopefully, and we're always looking for opportunities to be out in the community. Next slide.
Next slide. So if grassroots outreach is the boots or maybe sneakers on the ground, we use paid media as the air cover to promote a variety of issues and topics, including the Affordable Care Act and MAP Basic.
For the Affordable Care Act, as we have every year, we partnered with HAM to do paid media, including radio remotes at foundation communities in Spanish to get people enrolled in the marketplace. We use a variety of tactics. You can see them on the.
Today is November 16th, 2022.
It's YouTube.
And it is exactly 5:01. As a quorum of individuals.
About a variety of topics, including the Affordable Care Act, MAP Basic. We partnered with HAM, as we have every year, to do paid media, including radio remotes in Spanish. And then for MAP Basic, we wanted to enroll people in MAP, as Isela was saying, but we especially focused our media on areas where we have clinical capacity. And so we do streaming, online video. Everything that we do is in English and Spanish. Radio, we do a lot of, we focus more heavily on Spanish language radio to reach our patient population. We also do streaming audio on Pandora and Spotify. I either get one or the other, but not both ever. Digital display, so when you're perusing CNN or Lowe's or wherever you might be, you might see digital ads promoting the MAP campaign. Paid social media, different than what Anastasia was sharing with you. Nowadays, you have to pay to play to get your message out there to a really broad audience, and we do that with social media. And we do limited print, so we have bought advertising in El Mundo and The Villager and KUT for radio. So the results, 24 million impressions, meaning that's how many times our ads reached somebody. Somebody could see the ad more than once. This is a really impressive number, more than 51,000 engagements. That means someone either clicked on our ad, liked one of our ads, or shared one of our ads. And then more than 21,000 landing page views. So clicking through an ad to get to our website or the MAP website, again, it's a really impressive number. Next slide. We are also involved in crisis communication, whether it's a global pandemic, a once in a generation storm, or a public health emergency like Mpox. We do know how to step up and respond to a public health crisis, and we've done so. Just this last August, when City of Austin and Travis County declared that Mpox was a public health emergency, we worked with Austin Public Health and Travis County Community Care and others to produce a Mpox roundtable discussion that was broadcast live on Facebook. You can see some of the participants that were on the panel there. We had a live audience. Dr. Zamora was one of our panelists. And the Mpox, and it's called monkeypox here because at the time it was still called monkeypox. Now it is Mpox. But the discussion was seen by more than was viewed by more than 4,000 people on Facebook. So it had a far reach. Speaking of crisis communication, we are again working with, next slide, with City of Austin, Travis County, the Travis County District Attorney's Office, and Integral Care on an opioid crisis awareness initiative. So thanks to Camilla and our consultant, our marketing and advertising consultant, Belmont Icehouse, we developed a campaign, One Dose and It's Over. Again, everything is in English and Spanish, and created the Austin Travis County Opioid Awareness Coalition. This is just getting off the ground. The next step will be to place some paid advertising to some very specific target audiences. But again, an example of how we work with our partners to respond to public health emergencies. Yvonne?
Thank you, Ted. All right, next slide, please. We're going to be talking about some of the strategies, tactics, and activities that we employ to reach this objective, which is to get Travis County residents involved in the work of Central Health. Next slide, please. And while we're going to be talking about some of the most important strategies and activities we employ to get people involved, this isn't an all-inclusive list. The all-inclusive list is in the community engagement report that you receive every year around September. For Manager Kitchens, Manager Kitchen, we will give you the community engagement report that we produced last September so that you know the all-inclusive list, because this will not be the all-inclusive list. This is a highlight and a high-level overview. So most of you know about our Community Health Champions program. In fact, 2 of our board members are health champions, including Manager Musaitif and also Manager Matwani. And so our Community Health Champions is an annual program of Central Health that brings together diverse community members across Travis County to learn about and discuss and collaborate on our work. The program has been around since 2016. We have graduated about 300 people, and that is 300 people who have become ambassadors and taken the work of Central Health and the word of Central Health out into the community to get people to understand how to get care and how to get coverage. So this program is really at the core of our engagement and outreach efforts, because graduating participants receive, or they become a part of our network of ambassadors who consistently receive information on care and coverage, as well as involvement opportunities that they can then take to their communities. Next slide, please. So again, this is not an all-inclusive list of engagement, outreach, and activities, just an overview, but community conversations is one of the tactics that we employ to inform individuals in the community of the work of Central Health, as well as gather feedback from them. These community conversations are bilingual, and last year, for the first time, we took them out into the community. So not just at here at Cesar Chavez, but also in the Rumburg area, in Colony Park, and in Southeast Travis County. And last year, for the first time, we held the community conversations here in this room and stream live them also on Facebook, and they were very well attended as well. So last year we had 3 different topics for different community conversations. We had the voice of the community, which informed the healthcare equity plan. Then we also had another series of community conversations to circle back to the community with the healthcare equity plan, which was a result of the voice of the community work. And then we came back and closed the loop with community conversations around the budget. So that's what our cycle around community engagement looks like out in the community. And then again, not an all-inclusive list. There's also, we take presentations to community groups and so on and so forth. Another tactic that we employ is our community advisory committees. And so we formed community advisory committees back in 2018 to make sure that community members have a seat at the table when planning expansion projects. So at the moment, we have 3 community advisory committees, 1 in Colony Park, 1 in Hornsby Bend, and 1 in Del Valley. Members include residents, community partners, advocates, neighborhood association members or presidents, representatives from school districts, faith-based organizations, leaders, and also elected officials. They help us get to know and connect with each unique community to ensure that our collective work will impact the health of people with limited incomes. We have been meeting convening these advisory committees on an as-needed basis lately, but we also have been keeping members informed on the progress of each project all along the way. We do anticipate reconvening these committees as the openings of the Del Valley Health and Wellness Center and the Hornsby Bend Health and Wellness Center draw closer. So that's the community advisory committees. And then of course, public communication, an important thing that we also do to make sure that we are providing the public an opportunity to come and speak in front of the board as well. We do encourage our community health champions as well as the public at large, and specifically people who sign up to receive our updates to come and speak to the board as well. We send an email to them the week before each board meeting. Again, this is only a limited list, but you can see the number of activities that we executed on last year as opposed to the year before. You can see that the number of activities more than doubled. You can see that the number of participants has just went down a little bit, but that is because one, we did a lot more activities, and two, we were actually deepening our engagement. These activities were really meant to listen. So there were deeper engagement efforts going on. So with that, I'm going to turn it back over to you.
Thanks. So I talked about paid media or advertising that we use to connect people to care and coverage. We also do paid media to raise awareness about Central Health, our mission, what we do and how we do it. This is just one example during budget season. We did a digital media campaign and some radio to talk about our 2023 budget. So promoting the fact that we were increasing healthcare spending by more than $90 million for the upcoming year on things like service expansion. And so you can see the two clinical health and wellness centers and one specialty clinic that were part of that advertising campaign. The results, nearly 2 million impressions, more than 11,000 engagements. And again, we really like to see those landing page views. So that's one example of a more general awareness advertising initiative. I think one more slide. And next slide, yeah. So finally, last year was the launch of our healthcare equity plan. And so in December, this is just a little fun side, we developed a holiday campaign that we named or branded the Year of Equity. And maybe you received something, a digital holiday card, or hopefully saw something on social media. But essentially, we just wanted to celebrate all the equity work that Central Health is involved in. And I can't read that screen to you from here because it's too far away, but I hope that you can see it in your packet. And just know that we were promoting the communications and engagement work, the healthcare equity plan, our new DEIB council here at Central Health. So a lot was happening, and this was just a nice way to kind of put a bow on it, a pun intended there, for the holidays and share that with our community. And I think with that, I'll pause. If you have any questions, we're happy to answer them now, or we can do it in the future.
Yes. Manager Masaito. Well, thank you all. Appreciate it. First of all, I want to recognize all of your efforts and commend you on your social media responses. I've seen what really I appreciate is your patience with the community and public. There has been at times people who are asking additional information and they wanted to know more, and you were very patient in providing them with that information and providing your contact information for them to connect with you even in person, over the phone, beyond just social media outreach. So I commend you on that. Thank you for your positive reflection of this organization and for listening to community members and to agree to disagree at times. So I very much appreciative. And I'm happy I received, I believe, was it today or yesterday, an email about your upcoming celebration for the community health champions. That's always exciting when I see that. Much success and thanks for all your efforts. Appreciate it.
Thank you.
Thank you so much. That was lovely. We always want to hear from you. We could see more videos if you wanted, and
we may have some TikTok videos in our back pocket we can share with you.
That would be good. Thank you so much.
Thank you.
Yes, sir. Thanks. All right. So number 6. Oh, no, I'm sorry. Number 5, review the tentative reporting schedules for fiscal year 2023 activities and programs pursuant to the strategic directions established in the fiscal year 2023 budget resolution adopted by the Board of Managers. And Mike Gieslin and Monica Crowley will be presenting.
Yes, thank you. I think brief, because I know we need to do the budget and finance, but today, as this time of the year, a lot of updates on our report, which is our demographic report. Today, in addition to the demographic report, you also heard strategically where we're headed, and then our communications and outreach, which is core to everything that we do here in terms of how we connect with the community and provide transparency and ways to help build out the healthcare safety net system. And so I wanted to focus here. This will come back to the executive committee meeting, but there's a lot in here that will also be reported to the strategic planning committee meeting. In other words, this is the place where it will get reported. So I thought it best to preview this to both committees and give you ample time to see it. This report out schedule tracks the budget resolution, which you all adopted in September by category and subcategories. And we list the months that you'll be receiving reports on this. Now, we will obviously bring this back to the executive committee as the agendas are set by the respective committee chairs. And there's some flexibility here. Typically, it's a little bit more difficult for us to move some things up. It's good for us to move things back, but we're also mindful of building the budget. We don't want to move things so far back that the information can't be processed by the board as you all are thinking about the strategic directions on the budget. So again, this is really for awareness. You have time to look this over, and again, it'll come back before the executive committee. And subject to the call in the agenda setting of the chairs, you'll start seeing these reports come out, but it speaks to what Manager Musada brought up earlier is we're doing this planning, we're doing this great deep dive analysis, but what's happening in the meantime? This answers that question of here's what is happening in the meantime.
Nice.
We'll look forward to coming back to you. Thank you.
Yes, very nice. Thank you. And number 6, confirm the next strategic planning committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, February the 8th, 2023 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion for adjournment. Thank you. Thank you, Dr. Bell. And a second? Thank you, Manager Kitchen. And all in favor? Aye. And any abstaining? No. Thank you so much. We are adjourned.
Go into this meeting.
Yes. I already turned it on.
Good afternoon, everyone. Today is January 18th, 2023, and it is 3:37 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I'm going to move forward with our agenda. Our first agenda item is review and approve the minutes of the August 10th, 2022 meeting of the Budget and Finance Committee. Do I have a motion?
I motion that we approve the Budget and Finance Committee meeting of August 10th, 2022.
Thank you. Thank you, Chair. I have a motion in a second. All in favor? Any, sorry, it's been a while since I've chaired a committee. Any questions? You're abstaining. So Manager Kitchen is abstaining. So all in favor, who we have a vote?
Aye.
Aye. So the motion moves. Okay, so the next item, thank you for your patience and waiting. Receive and discuss a presentation regarding the Central Health Fiscal Year 2022 financial audit. And for this item, Lisa Owens will be presenting with Jimmy Rummel from Maxwell Locke and Ritter. Thank you all and appreciate your time.
Good afternoon. I'm Lisa Owens, Deputy CFO. I'm here to just introduce Maxwell Locke and Ritter and a summary of the results of our third-party independent audit report for fiscal year 2022. This audit is an audit of Central Health and our component units, which involves community care, the Community Care Collaborative in Sendero. And this work started back in November and continues through today and next week. So I'd like to take a moment to recognize the finance team at Central Health, which has done a bulk of this work, Patty Bethke, our controller, and Jeff Knodel, the CFO, but also Elizabeth, Cecilia, Joanne, Teresa ×2, Gloria, and Candace, all of which have done a lot of work to get us across to where we are today with the preliminary report. We will be back next week at the board meeting with a draft of the report, and a final presentation. But at this point, I'd like to introduce Jimmy Rommel, who is the partner from Maxwell Lock and Ritter, who led this engagement, to give you an overview of the report.
All right, thanks, Lisa. So good afternoon. Once again, this is going to be our review of the results of the audit that we have performed for Central Health's fiscal year ended September 30th, 2022. So if you want to go to the next slide, please. So this just gives a kind of overall just view of what the report looks like. The components of the report have not changed from what's been presented in prior audits that we presented to the board, but just it's made up of our independent auditors report. There's a management's discussion and analysis, which is basically Central Health's analysis of how the year went. That's the only portion of the audit report that's actually considered to be unaudited because it is management's kind of assessment of how the year went. We do review that, make sure there's no conflicting information with the audited piece of the information. We just want to point that out. Your basic financial statements. We also perform our audit under governmental auditing standards. So there's some additional reporting in relation to that. And then as Lisa mentioned, there are component units included in the final report for Central Health with Community Care Collaborative, and Sendero Health. Next slide, please. So kind of go over the key results from the audit. So there were a few new professional auditing standards that were implemented as part of the audit process for your fiscal year 22 audit. It really didn't change significantly the overall audit process. The one kind of main thing it did change, as you'll notice when you do get the final audit report, the independent auditor's report, previously the actual opinion paragraph in the independent auditor's report was on the second page of the independent auditor's report. Now it's actually gonna be the very first paragraph. So it is a, just a, it's more of a, just a presentational change, but want to make sure the board was aware of that. The portion of the document will look different than if you compare it to what's been presented in prior audits. But we are going to be issuing an unmodified or clean opinion, which is the highest level of assurance that we can provide as your external auditor. Next slide, please. And so as I mentioned before, our audits performed under government auditing standards. So as part of that, we review key internal controls over both financial reporting and then also do some compliance work in relation to any kind of significant contractual grant agreements, things like that. So we are pleased to report that we noted no material weaknesses in internal controls over financial reporting and also noted no reportable instances of non-compliance under government auditing standards, which is the highest level of information we can provide to the board in relation to those. Next slide, please. The other document that we will be presenting to the board next week, in addition to the audit report, is what's known as a governance letter. This is required communication at the end of the audit process. Kind of just goes through some of the overall components of the audit. It addresses if there's any new accounting standards, which this year, as we'll get to here in a couple slides, there was one new accounting policy that was changed for your fiscal year 22 audit. So that will be included in that final governance letter. Also want to point out that we had no difficulties in performing the audit. We definitely want to thank Lisa, Jeff, Patty, everyone here at Central Health for all their assistance with the audit this year. We had no audit adjustments as part of our audit process this year, and also no disagreements with management. So all that information will be included in the final governance letter that will be presented to the board along with the final audit report next week. Next slide, please. So this slide will just give kind of a year-over-year comparison of your statement of net position between your fiscal year 22 and your fiscal year 21 results. I want to point out, so for fiscal year 22, as I mentioned, there was one new accounting standard that was implemented related to lease arrangements. And so you'll see here some of the balances definitely have increased, especially as you compare them to the 2020 run results. So because the standard was effective for only fiscal year 22, that's why you don't go back and essentially restate had it been in effect in fiscal year 21. So just want to point that out, that you'll see total assets, total liabilities, and deferred inflows of resources are definitely higher than what they've been, but that's in relation to this new standard that was implemented during fiscal year 22. So just covering the 22 results, you'll see at the end of fiscal year 22 had total assets of about $994 million, total liabilities of about $404 million, to arrive at an ending net position of just under $591 million as of September 30th, 2022. Next slide, please. So this will be your statement of revenues, expenses, and changes in that position, which will show your revenues and expenses both for operational items as well as non-operating revenues. So for fiscal year 22, you had operating revenues of about $18.9 million, operating expenses of about $142.2 million. So an operating loss of $123.3. That was then covered by the non-operating revenues for property taxes, tobacco settlement revenues, and that total non-operating revenue amount was about $246.1 million. So overall, an increase in your net position in fiscal year 22 of about $122.8 million. I also just want to point out, if you look, there's a line for gain loss on disposal of asset. Just want to remind the board that last year, because of the demolition of the old hospital buildings, there was book value for those capital assets that had to be written off the books. So that's why you had a significant loss last year, which kind of skews the year-over-year comparison. But just want to point that out. That's not necessarily something you would definitely see on an annual basis. Next slide, please. So as I mentioned a couple times already, there was a new accounting standard that was implemented as part of the audit process this year related to leases. And so this impacts both when an entity is the lessor and also when the entity is a lessee. So Central Health actually has agreements where you are the lessor and also where you are the lessee. So for lessor agreements, you take the term of the agreement, including renewal options that are likely to be exercised. You look at all the payments and essentially you bring those dollars back to what they would be worth at the current point in time. And so you then take that amount and record a lease receivable for what you'll be paid in the future. And then you have an offsetting, what's known as a deferred inflow of resource, which essentially is just deferred revenue. So there's not really, when everything was first recorded as of October 1st, 2021, there's no net impact to your net position. You're recording an asset value and you're recording a liability value of the same amount. So there's no actual impact to your net position. Throughout the years, just the way the asset and liability balances get kind of reduced throughout the term of those agreements, there will be some slight differences between the two balances as of the end of each fiscal year, but not a significant amount that would impact your total net position. So just to point out, at the end of fiscal year 22, as I mentioned earlier, with your total assets and your total liabilities and deferred inflows going up significantly from 2021, you actually have lease receivables of about $244.5 million. And deferred inflows of resources of about $242.1 million as of September 30th, 2022. And then conversely, if you are the lessee, then you essentially are getting a right to use a underlying asset. And so you record a capital asset for the right to use that asset, and then you record a liability for what you'll be making in lease payments over the term of the lease agreement. So once again, at inception, the asset and the liability that come on the books, they zero out, and so there's no impact on your net position. So as of the end of fiscal year 22, you had about $42.7 million in capital assets and about $43.3 million in lease payables. And then when you get the final report, there will definitely be a more robust disclosure in the financial statements regarding the lease arrangements, the terms, the maturities, as far as looking at both the lease receivable as well as the lease payable arrangements. And then lastly on this slide, I know we've communicated this to the board in prior audits. For fiscal year 23, there's going to be another new accounting standard that will actually have a very similar impact that this lease standard did for fiscal year 22, but it relates to software arrangements. So the lease standard relates to tangible assets. So if you're leasing a building, if you're leasing land, but this standard, what it will address is if you enter into an agreement to use software so it's not your own software, you're essentially leasing it from a third-party vendor under a long-term contract, you will do a similar exercise that was done for the lease arrangements, where you'll determine what the overall value of the contract is. You record a right to use asset and you'll record a corresponding liability. So that is something that we'll definitely be working with your finance team on, because that actually could be a little bit more of a cumbersome exercise when it comes to evaluating all the types of arrangements that potentially could fall under the scope of this standard. So that is something that we'll definitely be making sure that we're communicating with your finance team ahead of time, so that way next year during the audit process, a lot of the initial kind of information gathering and kind of questions hopefully have already been addressed. So once again, that implementation can take effect for your fiscal year 23 audit. And so lastly, on this last slide, as part of our audit every year, we do review to make sure that your cash balances are either covered by FDIC insurance or properly collateralized, which they all were as of the end of the year. We also review the compliance under the Public Funds Investment Act, and we noted no instances of non-compliance under the PFIA. And then lastly, at the end of the fiscal year, had about 78.1 million of outstanding certificates of obligation and general obligation bonds. Of that amount, 4.3 million of principal is going to be due in fiscal year 23. And with that, I'll open up to any questions you may have for me. There you go.
Thank you.
Yeah.
Sorry. Thank you so much, Mr. Ram. Appreciate that presentation and for your time. And I also want to take this opportunity to thank our staff for your hard work and for this great report and your feedback. I am glad to hear that you had no issues and they were very responsive to you and to your team. I commend them on their efforts and the transparency process with our budget and audit moving forward. I just also want to confirm that the changes made do not have any financial impact to our central health's budget. It's just a reporting from what I understood.
Correct. So the cash flows that you would get from your lease agreements, that doesn't change under this new standard. It's just bringing on, essentially you're recognizing, all right, we're going to get cash flows over this certain length of time. We're going to recognize kind of what the total value of those payments would be at this point in time as an asset, have a corresponding liability. So yeah, it doesn't really impact from a budget perspective, because once again, it's not changing the actual funds coming in every year under those agreements. It's just changing the financial reporting requirements that have to be shown on the audit report. From an operational standpoint, yeah, budgeting is not going to really be impacted at all in relation to this.
Also it's similar to what the new changes for 2023 related to IT.
Yes. So yeah, once again, so those won't change your outflows as far as what you're paying for those software arrangements. It's just going to be bringing on an additional asset and liability for financial reporting purposes.
Thank you. At this moment, I will recognize my board members if anyone had any questions.
No questions.
No questions. Well, thank you. So this item, it was on for just discussion. We have no action on this item, and I look forward to seeing you again next week.
Next week.
Thank you, Mr. Rommel, for your work and for your presentation. Thank you.
Thank you.
I will move forward with our agenda item number 3. I understand it's been a long day. Be mindful and respectful to your time. So item number 3, discuss scheduling of upcoming budget and finance committee meetings. I understand we have another member on my committee who is not present, correct? Yes. But in moving forward, just wanted to let everyone know we will have a standing meeting that will occur right before the executive meeting and board of managers meeting that will take place, and it will happen around 4 p.m. In the meantime, we may also need additional meetings to address some of our really pressing financial issues. So just wanted your flexibility on that. So just wanted you to be more cognizant of the changes made to this committee, which are somewhat different from what we did in the past. It's just because we have a lot of pressing issues, and we also want to somewhat shorten our board of managers meeting. Do not want to be up all night with these financials, which can be very difficult late in the evenings. So that's really what I wanted to discuss on that item. Is there any questions, any concerns about this frequency?
No.
Well, with no said, we can move to our last and final item on this agenda. Confirm the next Budget and Finance Committee meeting date and time and location. Managers, our next Central Health Budget and Finance Committee meeting will be held just before the February Board of Managers meeting at 4 p.m. on Wednesday, February 22nd, 2023 at Central Health
Headquarters, 1111 East Cesar Chavez, Austin, Texas. At this time, I'm ready to accept a motion for adjournment.
I second.
We have a motion of Chair Bell and a second by Manager Brinson. All in favor? Thank you. And at this moment, meeting is adjourned. Thank you all.